So let's get started. This is the introduction to pharmacology, nursing 601. I think that you're going to learn a few things, but let's see. All right, so just to give you a little bit of background, I have quite a bit of clinical experience. I've been a nurse practitioner for about 30 years now. I really have also been educating at three different universities for the past 25 to 30 years. I've done geriatrics, I've done acute care, I've done walk-in, and for the past several years I've been doing family practice. So I think I can provide some appropriate context, but we'll see. All right. So in regards to this course, um, if you're looking at this video outside of a course, then just ignore these slides. But I do encourage you to do the readings for the things that you need to learn. I have provided some suggestions for some topics, but basically, since all the exams are online and quote unquote open book, um, there's not a lot of memorization. Just try to read things to understand them. Triple jumps are a three step process whereby you problem solve a case. I'll explain all those in class. Home study cases are cases that you'll do at home and hand in, and then I'll evaluate. Online exams, there's two of them for this course, a midterm and a final. As noted, they all are open for about a week and they're open book. Quizzles are multiple question quizzes that you can do as many times as you want. They're really intended to be a learning experience more so than an evaluation experience. We will definitely do a lot of discussion on the blackboard, and I do encourage you to contribute to the journal club. So lots of times we refer to this as a pharmacology course, but technically the name of it is pharmacotherapeutics, and there's a reason for that. Pharmacology really is much more of a science type approach to things. Pharmacotherapeutics is really a clinical approach to using medications. To use those medications, you do have to have a basic understanding of pharmacokinetics, the absorption, distribution, metabolism, and excretion of drugs. But you really want to learn those in a clinical context. When is it important? When is it not important? And use those. Pharmacodynamics is basically what does a drug do to the body? How does it work? So a beta blocker affects the beta receptors. It blocks the beta receptors and decreases that portion of the autonomic nervous system response. So that's what we mean when we say pharmacodynamics is what does it do to the body and how does it do it? So problem-based learning is sort of the approach that I use. I really think that if you identify a problem, then you figure out what are the learning issues that I need to understand to be able to really address this problem. And it really requires an active learning approach where the student is the person really driving the educational process more so than the faculty. The faculty is more of a guide by the side than a sage on the stage. And we are there to help and guide and really allow you to figure out what it is that you need to learn and actually figure out how to solve problems. Evidence-based practice, of course, undergirds everything. I encourage you to read my talk on evidence-based practice. I don't think it's the same thing as just following evidence-based guidelines. Evidence-based practice really requires clinical judgment on the part of the clinician, application to the individual patient, and an understanding of the evidence or research. So it's really not just looking at the research and then saying the research says you should do X, because there's very specific individualized issues that need to be addressed. So metacognition is really thinking about your thinking. So I really would encourage you to think about how you're reasoning problems. Again, I have a separate talk on the clinical reasoning process. I would encourage you to look at that. You know, it may actually not be for the pharmacology course, but it is available. and think about what it is that you need to learn, how you're thinking things through, making sure that you're being deliberate and not making silly mistakes. Obviously, there's thousands of drugs. We can't cover them all. We're going to try to really focus on the issues that are most important for primary care. And also, as this course morphs into a little bit more focus on acute care, we will also try to cover the medications that an acute care NP will need. So as you say, as part of problem-based learning, one of the key issues is identifying your own learning issues. What do I need to learn? Figuring out what resources you can use to learn it. Can you rely on those resources? Are they evidence-based? And can you trust them? Obviously, learning is a lifelong process. I've been a nurse for 40 years. I've been a nurse practitioner for 30 years. I have numerous things over the course of the week that I look up and try to figure out. So the good news is it's a lifelong process. The bad news is it's a lifelong process. Primary care is definitely a mile wide and an inch deep. Acute care is not quite as wide, but still involves multiple systems, multiple medications, and that's the challenge, is trying to figure out what you need to do to be effective in practice. So in regards to a medication, what's the best way to attack it? Well, if you understand the classes of medications, in other words, what do they do? Antihypertensives lower the blood pressure, antibiotics treat bacterial infections, then you'll at least have that. Then you break them down into families. Antibiotics, for example, there's quinolones, there's cephalosporins, there's penicillins, all of which work slightly differently. The penicillins and the cephalosporins interfere with the beta-lactam ring that's involved when producing the cell wall. So therefore, if you have an organism that doesn't have a cell wall, like a mycoplasma, an atypical bacteria, then those are going to be inappropriate choices. So you have to understand how the medication works and then figure out how that applies to a particular scenario, period. I will talk mostly in generic names. There's sometimes where the generic name is so long and cumbersome that I will use the trade name just because it's easier, but I'll try to make that clear, period. I do think that the use of generics is a better way to go, but sometimes it is just easier to say the trade name. Various medicines are given at various doses, various routes. We'll try to talk about those as we go along. We'll try to talk about the side effects of a medication, remembering that not all side effects are undesirable. Trazodone is an antidepressant that we found had a side effect of causing sedation. We use it for that side effect now because we use it as a sleeping medication. So not all side effects are adverse drug reactions. Really, in general, when we're talking about adverse drug reactions, we're talking about the bad stuff that happens. And obviously, we'll talk about contraindications when you can't give something, when there's renal issues or when there's pregnancy or those kinds of issues as we go through each medication and family. So mostly we use the metric system now. Every once in a while, you'll still see things referred to in the apothecary system, by ounces, especially. We do try to avoid the abbreviation cc's just because it can be misinterpreted as units if it's handwritten. I think it's less important now because we're not handwriting almost anything. Almost everything is done in the EMR, but it is considered best form to avoid cc's. We also talk about using leading zeros. So if you convert micrograms to milligrams, 150 micrograms is going to be 0.150 milligrams. Some of you come from other disciplines where leading zeros are not considered appropriate. You really need to get in the habit of using those leading zeros, just because if you write 0.125 and it's interpreted as 125, then that's a horrible medication error and it's potentially lethal. For each medication, we'll look at the metabolism. Most medications, 95%, do have half-lives. That's called first order metabolism. Others will have zero order metabolism, and they will be metabolized more slowly or differently, and we'll discuss those as we go through them. Medications are given by various routes. We'll talk about that as time goes on, and make sure you understand what each of these routes is. Intrathecally is into the spinal fluid. We don't do this very often, obviously, in primary care, but those of you in doing acute care might actually end up doing it. Or if you end up in pain, you might do injections. Age is something we'll talk about when we get to geriatrics. I have a whole talk on geriatrics later on. I would encourage you to use age as a flag, but not necessarily as a hard and fast rule. Remember that some people that are 70 have the metabolism of a 30-year-old, and some people that are 70 have the metabolism of a 90-year-old. So just keep age in mind as a flag to be thinking about whether or not there's any alterations that you need to make. So pharmacokinetics, there are there are 5 really good talks on the internet from handwritten tutorials. I would heartily encourage you to watch all of those. They're exceptionally good, and I won't recover that information here. Half-life is an important concept. You're going to see that the way that a drug is metabolized is important. The other thing is knowing where the therapeutic range is, when is the drug working. The other thing, of course, is that the toxic range is also sometimes close to this, and we refer to those drugs as having a narrow therapeutic window. Lithium is an example of that. So drug actions, how are they absorbed? Well, various drugs are absorbed in different ways. Some are absorbed topically, but again, most are going to be given orally. Most are going to be absorbed in the stomach or the duodenum, and then they're going to be distributed. It's important to remember that some medications have good penetration in various tissues, some do not. So a medication, just because it is shown to be effective in glass, for example, an antibiotic that you get a culture report back and it says that it's sensitive, that testing is done in glass. There is no way to really know whether that sensitivity is true in a person unless you really understand whether or not that drug penetrates those tissues. So Cipro does not have as good penetration of the respiratory tract, and therefore it's not considered to be an enhanced fluoroquinolone or a respiratory fluoroquinolone. The others, such as levofloxacin or moxifloxacin, are far better for respiratory infections than would be ciprofloxacin. When a drug is metabolized, most drugs are metabolized in the liver. First pass metabolism is when you take a medicine orally, and then it immediately goes through the liver before it really hits the bloodstream to speak of. And some drugs are highly metabolized, for example, morphine. So oral morphine is really deactivated by that first pass metabolism. So you need a much higher dose of morphine because it does have high first pass metabolism. You need a high dose if you're going to use it orally as compared to injectably. Half-life, as noted, half-life of a drug for most of them is first order, 95%. Some of the ones that have zero order are actually on the next slide. And then there's some things that you need to know as far as metabolism. Elders may metabolize differently. Ethnic factors may be a factor. I think we're going to understand this better as we do more testing for cytochrome P450 factors. But as of right now, we don't do that all that often. So just to remember, zero order kinetics, ethanol, phenytoin, salicylates, cisplatinum, fluoxetine, and omeprazole. Several of these are drugs we use pretty commonly. Ethanol has a fixed decline. I think it's 150 to 200 mics per hour. So if you have somebody that has blood alcohol of 200, then it'll drop by 15 an hour, but it'll take a while to do that. Obviously, don't quote me on these numbers. I have to look them up every time. But it's a fixed amount that it goes down by hour, as opposed to a half-life in which it decreases by 50% each half-life. Very different concept. So the drug actions, as noted, agonists will stimulate something. So a beta agonist like albuterol will stimulate beta receptors, so it'll dilate the bronchi. It'll make the heart go faster. Beta blockers will block most of those things, so it stops the bronchi from dilating. So therefore, beta blockers are not good drugs in respiratory issues, and it will slow the heart rate, which in many cases is the desirable effect. But if you've got somebody obviously that has an extremely slow pulse already, then obviously you don't want to give them a beta blocker. Some antibiotics work directly on the bacteria. They don't need receptors to work. Almost every other medication is going to need some kind of receptor within the body that it stimulates. We don't necessarily understand where those receptors are. We're still learning about the cannabinoid receptors, but it does seem to be a pretty logical estimation that every place is going to have a place to work. Some of these receptors are also important in regards to thinking where side effects may occur. So, in other words, there's narcotic receptors in the brain, which decrease pain, but there's also some in the gut, and therefore you'll end up with constipation. Imodium is actually a medication that has selective narcotic type receptors which work in the gut. So it does cause quote unquote constipation type effects. So it will be used to treat diarrhea. Pharmacodynamics, as noted, it's basically a relationship between the concentration of the drug and the response that you get. Basically, they map this. The science is something that pharmacologists spend lots of time thinking about. Clinicians very rarely spend much time thinking about it, other than is it going to work and what's the effective dose. Genetics, yes, we're definitely increasing the amount that we understand from genetics. Various textbooks, I did give the citation from DePiro, but there's lots of different places to find this information. And I think that mostly it's because different people produce different amounts and forms of cytochrome P450. Definitely there's certain patients, one example for me is ADD medicines seem to last 4 hours in some people and 12 hours in others. I don't think we really do have the technology to test for those cytochrome P450 receptors yet, but we're very close to it, and in fact, more testing may be available than I'm aware of. Again, this is just an example of if we can do therapy based on genetic tailoring, then we'll avoid a lot of the side effects and non-responders. Contraindications, so basically remember that pregnancy has classifications. These do not apply to breastfeeding. Breastfeeding has a totally different set of rules. Some medications that are completely contraindicated in pregnancy are safe in breastfeeding, and vice versa. So you need to actually look up the two separate issues. In pregnancy, you're not going to see many A's. Basically, it's saying that we've tested it in pregnant women and it's safe. Almost no drug company is going to test anything in pregnant women, especially now. B is about as good as you're going to get, and basically you've got animal studies plus observations that show that there hasn't been evidence of birth defects. C, we really don't know if there's a lot of issues and really only use these medications if you really think they're necessary. D would be a situation in which you would really only use it if the benefit outweighed the risk, if it was a life-saving situation, and you would do whatever you could to try to protect the viability of the embryo or fetus. X medications in general should not be used in pregnancy, although there are some that are intended to be an abortifacient, so that would be an exception to that. And really, most medications that are X's have been shown to cause birth defects. So nurse practitioner state laws vary enormously. They do change from year to year. In general, the most liberal are the two top corners of the country, New Hampshire, Maine, Oregon, Washington State. There's 20 plus states now that have independent practice. Just a few have supervision before that independent practice. Maine is one of those. Maine has 2 years of supervision, but it can be by an experienced nurse practitioner. It's not regulated by the Board of Medicine at all. It is completely done through the Board of Nursing. There's other states, including some of the southern states and some of the states that have a lot of medical schools, such as Massachusetts and Illinois and California, in which nurse practitioner practice is pretty restricted. The prescription of controlled medications, Florida was the last to fall in 2017. They can prescribe 3s, 4s, and 5s. To my knowledge, as of right now, they can't do 2s. In Georgia, you have to show your collaborating physician's name. In Alabama, there's a certificate that has to be filled out, and you have to pay extra for that. But basically, whatever state you're in, you really just need to investigate what are the laws, what are the options, and for some of us, it might actually impact whether or not we relocate to a certain state or do locum there or whatever. There is no state in which the physician has to co-sign a prescription other than for things like durable medical equipment, ordering home care, those kinds of things. But for medications, we can sign our own prescriptions. The American Academy, well, actually now the American Association of Nurse Practitioners does keep a state practice authority map on their website, so you can actually see how restrictive the environment is in a particular place. And obviously you can also go to the state board websites and see. Doctor is a protected title. As of right now, if you use the term doctor in a clinical environment, you could actually be cited for breaking a law, and this is a Class D felony. A Class D crime. So keep that in mind. I personally would much prefer that people call me by my first name, but this is a battle that is currently being fought, and we'll see how we make progress on this one. Types of medications: over-the-counter, behind-the-counter, legend-controlled, herbals, and nutraceuticals. We'll talk about each of these. Over-the-counter medications are just that, stuff you can go into a pharmacy, they're on the counters, you don't need a prescription. In many of the quote-unquote Spanish-speaking countries, Mexico, Spain, a lot of the Central American countries, antibiotics are over-the-counter. Some of those countries, even medications such as Ritalin, lots of medications can be over-the-counter. This can be difficult for people that come from those countries because they just can't understand why they have to come and spend hundreds of dollars to see someone like us to get a prescription for them. So Behind-the-counter medications, basically you have to give an ID and a signature. Pseudoephedrine is like that. Class 5 narcotics, such as Robitussin with codeine, can be done this way. Each state actually regulates whether or not you can just sign for these. The other thing is that each pharmacy will make a rule. In Maine, Class 5 narcotics can be behind the counter, but a lot of pharmacies will not do it except for their best regular customers, and they don't really make it known that you can get this medication without a prescription. Plan B for morning after pill used to be behind the counter. Now it's actually over the counter. Some places will actually still ask for ID just to prove that the person buying it is above the age of consent. Age of consent in Maine is 16, although 14 and 15-year-olds can consent if the person they're having sex with is less than 2 years difference in age. Legend medication basically just means it is only available by prescription. You will hear pharmacists sometimes use this term. It's a legend medication. Off-label prescribing just means that the FDA has not approved it. At least a third of what we prescribe is going to be off-label. There's a bunch of things that we use all the time that are not approved for certain use, but have been commonly used for that use for many, many years. Sometimes it is useful to be aware if you are going off-label just because you don't have quite as much legal protection. But as I say, it's definitely the usual and customary practice, and you're going to have a hard time practicing unless you don't prescribe off-label sometimes. Abusable medications are scheduled. A lot of the police call these narcotics, even though many of them are not pharmacologically narcotics. Schedule 1 drugs have no known use, although many of these drugs are controversial. For example, marijuana is a Schedule 1 drug. A lot of people feel like it does have a use. We just haven't researched it enough. Heroin is a Schedule 1 drug. Schedule 2 drugs are very abusable drugs. Things like morphine, generally what we think of as most of the regular narcotics, including hydrocodone, what we used to call Vicodin, but because it's brand name now, we almost never prescribe Vicodin. And even cocaine is actually Schedule 2 because cocaine does have limited use in ENT for doing nasal local anesthetic. Schedules 3s, 4s, and 5s are less abusable. You can actually put refills on 3s and 4s, and even 5s. Schedule 2s have to be done with either special paper, although pretty much that's gone. Now they have to be done through an EMR with a unique one-time password double validation system. So everybody that prescribes controlled medications needs to have a DEA number. For those of us that are nurse practitioners or PAs, we get an M prefix. So mine is ME0026383. So the M stands for that less than politically correct term, mid-level, and the E is my first initial of my last name, and then the number. These need to be given if you're prescribing anything Schedule 2 through 5, and noted, we will rarely use the special paper anymore. It really is a two-factor validation now. And we did talk a little bit about marijuana. We'll talk much more about marijuana in the course. Suboxone is now a medication that you can use for medication-assisted therapy, MAT, for narcotics. With an X waiver, NPs now need to have a 24-hour course. Physicians only need an 8-hour course, which I'm not sure. I don't think they're 3 times smarter than we are. But at any rate, that is what's required, is a 24-hour course. Herbal therapies, alternative versus complementary. So if you're using something instead of traditional treatment, that's alternative. If you're using it along with traditional treatment, that's complementary. And so you need to ask yourself, am I going to recommend these things? Under what circumstances am I going to recommend these things? The evidence base is generally nowhere near as strong for these kinds of things. On the other hand, many of them are relatively harmless. A lot of people that do diabetes recommend the alpha lipoic acid for peripheral neuropathy, just because it has essentially no side effects and there is anecdotal evidence that it works. There is not a lot of hard research that says that it works, and you need to decide, am I going to recommend these fairly pricey supplements, or am I going to stick to traditional therapies? Homeopathy is not what most people think it is. Homeopathy is the concept that like treats like. So if you have somebody with diarrhea, you basically give them a laxative. The problem with that is that when they first started doing this many years ago, Hahnemann was the first homeopathic physician. When they first started doing this years ago, people didn't respond very well. They actually got worse. So what they've done is they actually have diluted down those medications. And so you'll see 2x, 4x, 8x, 16x, 32x. Sometimes they're diluted down so much that there's actually a question of whether or not there's any molecules left from the original medication. But at any rate, in a true homeopathic situation, it is dilutions. A lot of people mistake homeopathic for naturopathic, and naturopathy is definitely something that is natural treatments. Anything that occurs naturally can be prescribed in some states. So in other words, morphine can be prescribed by a naturopath, but Demerol could not, because Demerol is a synthetic medication. Varies a lot from person to person as far as what they're treating with. Some of us use natural therapies. Patients sometimes assume that natural is better than synthetic. I'm not sure that there's any real logic behind that, because heroin is natural and tobacco is natural, and there's a lot of these things that are natural that are extremely dangerous. So at any rate, you just need to understand the terms. Elements of a prescription: if you're in the EMR, it's going to automatically fill these in or prompt you to do so. One of the big ones that you need to think about is that for many prescriptions, we now need to include an indication. So for people with ADD medicines, if you don't include the indication, the ICD-10 code for that diagnosis, it won't get paid for. Another one is that if you're prescribing any narcotics in Maine now, you need to stipulate whether it's indicated for acute pain or chronic pain. So as you learn to do the various medications, you'll learn what needs to be on each prescription. Nutraceuticals, it really doesn't mean anything. There is no legal meaning in the United States. Generally, these are dietary or vitamin type supplements that are used to treat. If you're trying to go for an FDA approval, that basically makes them an over-the-counter medicine. So most of them just make these claims, and then at the end of it say, we make no claims for health benefits, which is pretty contradictory, but keeps them from having to go to FDA approval or review. If one goes for FDA approval, one needs to list all the potential side effects in any ads, and that is one of the things that happens with prescription drugs. If you have even a small number of side effects, then you have to say them on your television and other ads, and it hurts your marketing. Axona is a supplement that's used for Alzheimer's disease. They have not gone for approval. It is had alleged benefit, but it is fairly expensive. So I would heartily discourage people from recommending this. So examples of nutraceuticals that you may want to use. CoQ10 does seem to have some benefit if used with statins. The number of people that get joint pain and muscle pain does go down pretty substantially, so that's something to think about. Glucosamine chondroitin does have some evidence for joint pain. It does seem to work in some animals, so it does not seem to be placebo. Some people recommend niacin because it really has a great impact on the lipid profile. It lowers the LDL, it raises the HDL, it lowers the triglycerides. Unfortunately, it really does not have any evidence for um, decreasing deaths. Fish oil, as noted, there's a lot of people that recommend fish oil for health. The heart benefits seem to have been debunked. I do recommend this for people that do have high triglycerides just because I don't want them to get pancreatitis. We already talked about the alpha lipoic acid, and the SAMe seems to have benefit for lowering liver function tests that are elevated, as well as maybe some antidepressant effect. Whether lowering the liver function actually makes the liver function work better is an open question. Bad drug. One of the things that makes it hard is that people are very pharmacophobic. They're very afraid of medications, and one of the reasons is that the lawyers are saying that all of these things are bad. Obviously, I tell people all day long, all medicines are magic, all medicines are poison. The right medicine for the right person at the right time can be life-changing. The wrong medicine and side effects can be dangerous and problematic. So unfortunately, some of these medicines have had adverse drug reactions. You need to investigate each one yourself to decide whether or not that risk outweighs the benefit. Many of these medicines, as noted, have substantial benefit as well. No matter what, if you are going to prescribe any of these medicines, or essentially any medicine, you do want to document that you've had an informed consent type decision and that you've explained potential downsides of some of these medicines. So as noted, 1-800-BAD-DRUG and several other sites on the internet are constantly coming up with medications that allegedly cause problems. Whether these are real or whether these are imagined, I will leave to your own investigations. Malpractice. So whenever you're prescribing, you need to keep in mind that something bad can happen. For professional negligence to be proven in court, you have to have a duty to the patient. So if you are seeing a patient in a clinical environment and have a formal relation, you have a duty to them. You have to have made a mistake. So, for example, a patient that is documented to be allergic to penicillin, if you prescribe penicillin, well, that's an error. Bad outcome has to have happened, and they have to be able to prove that the bad outcome the screw up caused the bad outcome. So you prescribe penicillin for somebody that it says they're allergic to, nothing happens. This is not professional negligence, although someone might discipline you for not checking more carefully for allergies. Another case would be someone is not documented to be allergic to penicillin, but they have a bad reaction and they die. You really didn't make a mistake. There was no way that you could have known that. So basically, there has to be a standard of practice that has been not observed. Something bad has to have happened, and they have to legally be able to prove that the mistake is what caused that bad outcome. Medication errors, as noted, all medicines are magic, all medicines are poison. They estimate that as many as 100,000 people die each year from medication errors and medical errors. Some more recent articles suggest that this might be an underestimation. When you're in an environment, if you make mistakes, most places have gone to just culture, which means that if it is a systems error, you shouldn't be held responsible. However, if you really made a mistake, you may be held responsible, as opposed to the blamelessness, which is assuming that everything is always a systems issue. Medication ordering, fortunately, we often have an extra layer where the pharmacy will catch things that we make mistakes on. But unfortunately for staff nurses, they often don't have that layer, and they often are cited for errors much more than prescribers are. And don't forget, don't prescribe something just because you can. you really need to be convinced that a patient will improve from the medication, and they need to understand the potential risks and benefits. 5-year rule. So I don't prescribe a new drug until it's been out for at least 5 years, with very rare exceptions. If you look at the list of withdrawn drugs on Wikipedia, there's at least 50, seem to be an increased number each year. So a lot of these medicines do have very substantial side effects. Don't necessarily jump on the bandwagon just because there's something brand new. The Jublia that everybody was so excited about for treating toenails was only really about 15% effective. It cost over $4,000 a year. And Vicks VapoRub on the toenails was actually about 20% effective and cost less than $50 a year. So, just keep in mind that just because we can prescribe something doesn't mean we should. And when you have a patient that's actually taken a medication that they shouldn't have, if they've double dosed on something, you can definitely call poison control and get their input. Example is, I had a patient that was on a Spiriva inhaler, and instead of inhaling the capsule, they actually swallowed the capsule. So I called poison control. They said, yep, this happens all the time. There's a minimal dose in that capsule. There's no adverse effects. Don't worry about it. So it's a really quick and easy thing that you can do if you're on call or if patients come in, rather than have to send them to the emergency room, because to be honest with you, this is what the emergency room does 9 times out of 10. So this should complete this section. There is a part 2 as well.